So today we'll discuss acute management of asthma first and then COPD. First of all, we will revise pathophysiology of asthma. There is hypersecretion of mucus and inflammation which leads to narrowing of the airway, but it is transient. And after the trigger is removed, the airways they get open again. Now, how do we diagnose asthma? As I've already told you, one way is to diagnose it with spirometry, and other way is FeNO testing. Nitrous oxide is actually a mediator which is released by eosinophils, and eosinophils they play a very important role in inflammation in asthmatic patients. So, if the level of FeNO is greater than 60 ppb in adults, it is diagnostic of asthma. It has got also many other implications in the management of asthma, like it tells us that which patients of asthma they will respond to inhaled corticosteroid therapy and whether patients they are adherent to their therapy or not. Then after that we will categorize asthma into mild to moderate variety, then severe asthma, and then life-threatening attack. In mild to moderate asthma, usually partial pressure of oxygen is greater than 92. Patient is speaking well, and his pulse rate and respiratory rate they are less than 110 beats per minute and less than 30 respectively. While in severe asthma, peak expiratory flow rate is between 33 to 50% of predicted value. Partial pressure of oxygen is less than 92. Patient is unable to speak in one sentence, and pulse rate is more than 110 beats per minute, and respiratory rate is more than 30 per minute. And in life-threatening asthma, again partial pressure of oxygen is less than 92%, and peak expiratory flow rate is less than 33% of best predicted value, and patient has got silent chest, and he may develop central cyanosis, and he's confused, and partial pressure of carbon dioxide either it becomes normal or it starts rising, showing type 2 respiratory failure. Usually in asthma, there is type 1 respiratory failure, that is partial pressure of oxygen and carbon dioxide both are low. So when partial pressure of carbon dioxide it becomes normal or it starts rising, this is quite alarming sign. Now, how do we manage patients of acute severe asthma? As long as the patient is not having life threatening attack and he is in the severe category of asthma, we usually give patient oxygen, and we give a short acting beta agonist, that is Ventolin, and short acting antimuscarinic, that is ipratropium bromide, through nebulization every 15 minutes. And we can also give oral or IV glucocorticoid depending upon the patient's condition. And after that, if patient does not improve in 1 hour, we can also think of giving IV magnesium sulfate and inhaled corticosteroids. Suppose if the patient he does not improve after this management of 1 or to 1.5 hour, or he develops life-threatening characteristics like confusion, drowsiness, or normal pressure of carbon dioxide or increased pressure of carbon dioxide, we think about ECMO, which is extracorporeal membranous oxygenation or artificial lung. It is just like artificial kidney, that whole blood of the patient is passed through an artificial lung or artificial machine which removes carbon dioxide from the blood and adds oxygen into it and then returns it to the patient. And we can also think about giving assisted ventilation, bypassing endotracheal tube and then starting invasive ventilation. Then comes COPD. Same changes they happen as in asthma, that is in excessive mucus production and inflammation, but the changes they cause damage to the alveoli permanently. So in acute attack of COPD, what we do is that we give oxygen therapy, then we give IV antibiotic if the underlying cause is infection, then we give short-acting beta agonists like salbutamol and ipratropium bromide, just like as we did in asthma. If there is no response, instead of magnesium sulfate, here we can give IV aminophylline. If still no response and pH is less than 7.35 or it is even lesser than that and partial pressure of carbon dioxide is rising, we can think about giving non-invasive positive pressure ventilation. Here, one thing is important, that in COPD patient, usually carbon dioxide is already high. So the brain of such patients, they are tuned to high carbon dioxide. So the breathing rate is not increased if carbon dioxide would further rise. So only drive to the respiratory center, or only stimulus to the respiratory center, is hypoxia. So we do not eliminate hypoxia. We give oxygen, and we maintain oxygen saturation of the blood between 88 to 92%.